Morning. Good morning to the speakers as well as the students. I'm really happy to introduce two very eminent persons in dermatology. One is Dr. Roshni Menon, the other one is Dr. Gopinath. Dr. Roshni Menon has recently resigned from Medical College service. I was wondering when I heard the news. Anyway, I wish her all the best in the coming years. She is such a very enthusiastic person. I know her from very early time. She headed the department of Sri Venkateswara Medical College, Puducherry, and her students secured many accolades, especially when we started a program for postgraduate students all over all India for making a small strip. And one of our students won the prize. And such an enthusiastic person suddenly getting out of medical education is a really wonder. Anyway, she is very brilliant during her studies, during her career, and she has some interest, special interest in urethral discharges. I mean, mainly in sexually transmitted infections, and this urethral discharge or gonococcal urethritis is very dear to her. So I thought I will utilize that knowledge for the sake of our students all over India. I invite Dr. Roshni for the talk. Over to you, Roshni.
Thank you, sir. Thank you so much for the kind words. And before starting, let me thank especially you, my teacher, and you have been an inspiration to all of us right from MBBS days in Thrissur Medical College. And if you continue to do so. So definitely, even though I am out of teaching, but still I'm not stopped teaching. Whoever are interested, PGs, and these kind of academic programs, I am very much interested to take part. So thank you for the good words, sir. And I also thank East West Pharma for this opportunity. So I think we will, I'll share the screen now. So today, give me a minute, please. Okay. Hope I'm audible too.
Yes, madam, you're audible and screen is visible.
Yes, yes. So we'll just start. So today, my talk is much limited to the gonococcal urethritis part. So first, I think this is a very vast topic, and I have limited only to the clinical features, diagnosis, and treatment. The treatment challenges. What you come across, especially when you're dealing with a patient of gonococcal urethritis. So we'll just start with a case scenario. So this is like a person presenting with this kind of picture after 5 days of unprotected sexual intercourse with an acquaintance. And on examination, I think you all can notice the erythematous and edematous extraurethral meatus with copious purulent discharge. So when you get such a case, it can be any kind of urethritis, isn't it? So I'm more focusing on gonococcal urethritis today. So how will you approach this case? So number one is history. We have already got a history of his exposure with an acquaintance 5 days. So definitely incubation period is roughly around 5 days, and the symptoms, mild dysuria and purulent discharge. So this itself will make you think of in line of gonococcal urethritis. But in addition to all these things, you should be aware of the other kind of affections of different organs which can be associated with gonococcal urethritis. So you should be looking for these symptoms. Unless you are aware, you will not look for these symptoms. So one is common complication is epididymitis, where the patient can present with along with a fever and a unilateral testicular pain and swelling, and any history of hesitancy of urine or dribbling of urine with perineal or pelvic pain. And pharyngitis. See, pharyngitis, proctitis, and all those are uncommon associations. But still, we should be aware as doctors, we should be aware of all these things. So you can usually these two things, that is pharyngitis as well as proctitis, are asymptomatic usually. But sometimes some people can have sore throat, some exudation along with cervical lymphadenitis. I'm very sure whenever we come across a person with urethritis, we won't look for a cervical lymphadenopathy. So you better at least ask whether you have a problem with some problem with the pharynx. And similarly, proctitis is also usually asymptomatic, but these kind of symptoms can occur in certain patients. Now, regarding conjunctivitis, conjunctivitis is not limited to neonates. Adults can also have conjunctivitis, especially when, mostly occurs due to auto-inoculation from the source. So, redness, too much of chemosis and lacrimation with pain, and pre-auricular lymph node enlargement. So, this should make you think of these kind of complications along with the presentation of urethritis. So gonorrhea, as we all know, it's the oldest known disease of mankind. It has its mentioning in the Bible also. It's a strict human pathogen without any animal or environmental reservoir. Now, what are the clinical features? Everybody is well versed, all postgraduates, well versed with the clinical features of gonococcal urethritis. Incubation period is around 3 to 7 days, can go up to 10 days. And discharge, urethral discharge and dysuria are the most common symptoms. There are different types of urethral discharges, but still here, mostly we see a purulent or mucopurulent discharge. Sometimes when the patient passes urine, you can even see a visible mucus threads in the urine. Actually, what are these threads? They are nothing but a cast of the Litter's glands, paraurethral gland of Litter, due to the Litteritis, which is associated with gonococcal urethritis. And sometimes the patient can be totally asymptomatic also. And the inguinal lymph node enlargement may or may not be present. It can be unilateral or bilateral. Now, mostly whenever we think of gonococcal urethritis, we always refer to men. Can it occur in women? It is also possible. However, the commonest presentation in women is gonococcal cervicitis, which is usually asymptomatic. But in patients who have undergone hysterectomy, there is a higher chance of development of involvement of urethra. So usually again asymptomatic, it may present with dysuria. Now, what are the common complications you can get when a patient acquires urethritis, gonococcal urethritis during pregnancy? So pregnancy is associated with lots of obstetric morbidity like abortions, chorioamnionitis, preterm birth, etc. And the risk of maternal to child transmission is also high, like 30 to 50% of cases. Similarly, a baby born to a mother with urethritis or gonococcal infection anywhere in the body can develop these kind of ophthalmia neonatorum, pharyngitis, arthritis, etc. So it is very, very important to diagnose and immediately treat, especially when the patient is a pregnant lady. So these are the complications. I just want to list out the complication of gonococcal urethritis. In men, most common is epididymitis. So look for painful, tender, or unilateral swelling of the epididymis. That is basically present as a scrotal swelling. And penile lymphangitis, typhusinitis, and Litteritis. This periurethral abscess and urethral strictures are very rare after the era of antibiotic, regular and very complete antibiotic use. Cooperitis and prostatitis. These are I've just listed the complications. In women, PID is most common, especially around 30% PID. Sometimes when you the literature shows that it is associated with this kind of sexually transmitted urethritis. So sometimes the patient can even present with acute PID with the febrile salpingitis, endometritis, like that. And Bartholin's gland abscess is also possible, especially when it involves lots salpingitis. It can cause it is a major cause for infertility. So these are the complications in men and women. So in this picture, it is very visible what are the major organs which are affected in gonococcal urethritis. Now, systemic complication, as you know, all postgraduates are aware of all these things. Disseminated gonococcal infection itself is a major presentation. So I'm not, included in this presentation because it's a big topic as such. Gonococcal endocarditis, gonococcal meningitis, and perihepatitis. And perihepatitis, as you know, it is more common with chlamydia, but it can also occur in gonococcal infection. Now, how will you diagnose? See, basically in our setup, and especially in a basic medical setup, it is mostly history and physical examination. So that is how, but that actually just give you a presumption of diagnosis only. It doesn't, completely confirm the diagnosis. So in that case, you can do a positive leukoestrase dipstick test or take urethral phosphoid specimen of urine, centrifuge it and look at the urinary sediment under the microscope. If it is more than 10 WBC per hyperfill, it suggests urethritis, but it doesn't suggest a gonococcal urethritis. Only the presence of a gram-negative intracellular diplococci or a purple diplococci by methylene blue or gentian violet stain. These are the other stains which are used. So in that case, it gives a confirmation of gonococcal urethritis. But the test of choice is nucleic acid amplification test. Culture used to remain a gold standard test, but the problem with culture is like, the culture productivity, that is a bit difficult, and stringent techniques are involved in culture, getting a positive culture, but it's a very important tool in antibiotic resistance. Now, again, I have told you, like when no tests are available, the diagnosis is presumptive based on the patient's symptoms, incubation period, and the size. In addition to this, all patients should be tested for other sexually transmitted diseases as well. Now, how to collect the specimen? Now, the specimen collection is a very uncomfortable procedure for the patient, so that you should remember whenever you are doing this, you should do it very, very gently, especially because I'll just concentrate on urethral smear collection. Insert 2 to 3 centimeters of the probe into the urethral meatus and rotate for 2 to 3 times. Similarly, you can collect cervical, rectal, pharyngeal swabs. So these are the, now what will you use for collection of swabs? So culture specimens, you can use a plastic or wire or nichrome wire or a platinum wire loop as a probe, but the tip should be a rayon, dacron or calcium alginate, especially when you are going to look for gonococci. One word about calcium alginate. Suppose you are going to test a NAAT for chlamydia, calcium alginate is not preferable for chlamydia. And totally wooden shafts and cotton chips should be totally avoided because these are toxic to the gonococci. So as you all know, gonococci is a very, very fragile organism. So when you are, suppose you're planning to inoculate it in the culture media, you have to do it along with smear preparation. So take a smear, collect the specimen, make a smear, and immediately you inoculate in the culture media. So that is how you should do it. And that should be pre-warmed culture plate. Now, smear and stain. So again, we know gram stain is the one which we regularly use. Now, in addition to the gram stain, both methylene blue as well as gentian violet, both can be used. And you get a purple colored gonococci in methylene blue and gentian violet staining. Whereas gram stain, as you know, it's a gram negative intracellular diplococci with a kidney shaped or a coffee bean shaped diplococci. Now, this is apt for the urethral smear in a symptomatic male. Now, the sensitivity specificity changes if the patient doesn't have symptoms or if it is a woman. So, or the other extragenital site. So, the sensitivity and specificity changes. So, this is apt. This is the best method. If possible, a positive gram smear really confirms the diagnosis in a urethral smear in a symptomatic male. So sensitivity and specificity is very high, as you can see in this, in a symptomatic male. Now, correlation is also very good. That is gram stain, methylene blue, gentian violet, correlation is also very high. So you can use any of these stains. But lower, in an asymptomatic male, the sensitivity is low. So in that case, a negative gram smear does not rule out the gonococcal infection. That point you have to keep in mind. Now, regarding culture, the commonly used selective medium is a Thayer-Martin medium or a modified Thayer-Martin medium. So basically, this is a medium which has some additions like vancomycin, colistin, nystatin and all to prevent the overgrowth of contaminants from the atmosphere surrounding it. And modified Thayer-Martin medium has an extra trimethoprim added to it to prevent proteus from growing. So basically, you know, this gonococca is a very, very fragile organism. It's basically an aerobic organism. Still, it needs an environment of 3 to 7% carbon dioxide with incubation at 35 degrees. Usually, they incubate it for at least at 48 hours for a good result. Now, what's the advantage? Assessment of antibiotic susceptibility. Nowadays, the antibiotic resistance is on the high, so that sometimes in a person who is not responding to the usual line of treatment, antibiotic susceptibility testing is very important. But the problem is, it is time consuming. Minimum 48 hours to be required, and the rectal and pharyngeal specimens, poor culture recovery rates. Why? Because of the other non-pathogenic Neisseria which will be present in those areas. So sensitivity and specificity is very high in a urethral specimen in a symptomatic male. So in this picture, you can see both two culture plates. One is actually that is chocolate agar. You can see that culture of gonococci, soft pinkish colonies, granular surface and crenated margins. So usually they will take it and do a biochemical test for this isolates and specifically oxidase and catalase positive for gonococci. And this is the diffusion disc assay. And here you can see they have put the antibiotics and you can see the clearing of gonococci surrounding. So from this itself, we will be able to know which disc is resistant, which disc is sensitive for the gonococci. And this is very important, especially when you come across a person who is not responding to the usual lines of management. Now, nucleic acid amplification test, this is the most preferred test due to the accuracy and the rapid results. Only thing is it's a bit expensive. Here, the advantage is even clinician collected as well as a patient collected specimens can be used, and high sensitivity, more than 95%, and even at extragenital sites. Especially CDC recommends only NAAT for pharyngeal specimens. And the problem is you cannot test antimicrobial susceptibility, but nowadays even some new molecular tests are in the pipeline even to test an antimicrobial susceptibility. And this is an expensive test. But if available, this will be the best test to do. So NAAT specimen, these are the different types of specimens for which NAAT can be done. For us, urethral swab, a urethral smear, if it is there, immediately you can take an imprint smear, or you can collect the specimen as I have already shown you. Or if there is not much specimen, you can milk the urethra. Or sometimes if it is difficult, uncomfortable for the patient, you can even take a 20 to 30 ml of initial urinary stream and then just spin it and take the sediment and observe it. So you can use it for staining purposes as well as for NAAT specimens. These are the other tests which are mentioned for the postgraduates' sake. I have listed these tests. One is the leukocyte esterase dipstick test. Now, this is basically, this enzyme is produced by WBCs in an activated stage when they are recruited for inflammation or infection. So that just shows there are a lot of WBCs in the specimen. So that's all. It is not a confirmatory test for gonococci by any chance. But the presence of this gives us an idea there is a lot of WBCs in the particular area. Along with this, if you have a confirmatory test done, then it gives a positive. Now, there are enzyme immunoassays like antigen detection methods not widely used. And its importance is only in high, positive predictive value is only high in areas of high prevalence, and nucleic acid hybridization technique. So these are all like sensitivity is much less compared to NAAT. Now, what are these point of care tests? So that is one thing which you very regularly come across when you come across these kind of tests in CDC. So basically, these are tests which are which should be very simple to use, and which can identify and immediately treat the gonococcal infection at the level of patient encounter. This is very important because in an STI clinic, follow-up is very difficult. Many people will just not turn up. So it is best that you immediately diagnose and give the treatment to these patients whenever they come for first consultation. Now, FDA has approved NAAT and Gene Experts. Gene Expert is basically a real-time PCR. So all these assays for POC. But the problem with this, we all know the feasibility in our setup is a bit less because of the financial constraints. So due to lack of resources, gram staining itself is used in our setting. So if this point of care, so we use mostly a gram stain. That is our standard. If possible, NAAT is there, well and good. So if POC is available, presence of more than 2 WBCs per high power field in a high prevalence setting. That is, high prevalence setting is an STI clinic. That is a high prevalence setting. So even 2 WBCs are important, significant. Whereas in a low prevalence setting like a general derm OPD or a family planning OPD, something like that, more than 5 WBC, we take it as significant. Now, presence of this with intracellular diplococci is considered as presumed as GU, and without intracellular diplococci is a non-gonococcal urethritis. Now, if POC is not available, so then you go ahead and make diagnosis and give treatment. Leucopurulent discharge if present, leukocyte esterase if positive, or more than 10 WBCs on one specimen after spinning of the urethral first void urine. But if at all it is there, it is always advised and better to do a urine NAAT for specific identification of organisms. Now, treatment of gonococcal urethritis. Now, this is as per CDC guidelines for individuals who weigh less than 150 kilogram. It is injection ceftriaxone 500 milligram, and more than 150, it is 1 gram Amsel. And if you are able to diagnose chlamydia, if you are able to rule out chlamydial infection, you need not give the doxycycline. But if you are not, it is better to give a presumptive treatment of chlamydia along with this, which is tab doxycycline 100 milligram for 7 days. Now, if suppose somebody has hypersensitivity to cephalosporins, the option is azithromycin 2 gram oral with gentamicin 250 milligram IM single dose. And it is the same treatment for uncomplicated urogenital, rectal, and pharyngeal gonorrhea. If ceftriaxone is not available, you can use the other new generation cephalosporin injectables like ceftizoxime, cefotaxime, and cefoxitin with probenecid. And there are a mention of these 2 drugs also. Sometimes you will see in MMWR, that is gemifloxacin. Now it is no longer recommended because of limited availability and the problem with concerns with antimicrobial stewardship. Spectinomycin is effective for uncomplicated urogenital and anogenital infections, but poor efficacy for pharyngeal infections. And definitely cost is high, all these things. So it is better that you go ahead with ceftriaxone. Gonococcal conjunctivitis, as I told you, adults can have acquired conjunctivitis by auto-inoculation. In that case, you have to give injection ceftriaxone 1 gram stat, along with presumptive treatment for chlamydia. Now, pregnant women, it is the same regime. But when you add presumptive treatment of chlamydia, a word of caution, add azithromycin instead of doxycycline. And if any of them have severe allergy to cephalosporins, ideally you should desensitize as per CDC. But if difficult to desensitize, treat it with gentamicin with azithromycin. So, and so much of studies are going on regarding the resistance pattern of gonococci. So in that case, the minimum inhibitory concentration keeps on climbing for especially the oral cephalosporins. So after a particular level of minimum inhibitory concentration, it is regarded as ineffective for gonorrhea. So similarly, is the story with cefixime. So even though some people give cefixime 800 milligram stat for treatment, it is better to avoid it and go ahead with the injections. So how will you follow up? Definitely, you should advise the patient at the time of first appointment itself to abstain from sexual activity for 7 days after treatment and until all the sex partners are treated. And definitely, these kind of high-risk people, it is better to do retesting NAAT for gonorrhea after 3 months after treatment. Now, text of cure, that is, once you give full treatment, should we test it again? CDC does not recommend it for uncomplicated urogenital and anogenital infections. But oropharyngeal gonococcal infection, it is recommended. Why? Because the pharynx is a very difficult area to get a complete clearance of infection with gonococci. The antibiotic penetration is difficult, and the crypts are so deep that it has a particular mechanism by which it resists the antibiotic susceptibility in that particular area. So the patient should be, it is better to do a test of cure, and patient should be under regular follow-up. This is very important with MSM patients. And preferably you do a NAAT, preferably 14 days after the therapy. Now, suppose certain people, there will be persistence of symptoms even after treatment. So what are the problems associated with that? What are the causes? So one is poor adherence to the regime. Second is a reinfection, antimicrobial resistance, and co-infection with other organisms. So it has been seen that along with gonococcal urethritis, around 30 to 40% patients have co-infection with chlamydia also, and maybe these organisms also. So recommendation is again repeat NAAT for GC, NAAT for chlamydia, and whatever mycoplasma genitalium, trichomonas, vaginalis, all these things, urine-based NAAT tests are available, and treat it accordingly. And repeat testing of these pathogens and with NAAT is warranted even 3 months after treatment, because there is a high rate of reinfection, especially in high-risk groups. Now, treatment failure. When will you call it as a treatment failure? When the symptoms do not resolve within 3 to 5 days after treatment, and you get a positive culture more than 72 hours after treatment, or a positive NAAT more than 7 days of treatment, where there is no history of sexual contact during that period, we call it as a treatment failure. But again, what is to be done? Collect relevant clinical samples, and again do NAAT. And you have to really talk with the patient and find out whether it is a reinfection or a resistance. So if it is a reinfection, again, do the same regime. We follow the same regime. But if it is resistance, then you can try treatment with injection gentamicin 240 milligram and oral azithromycin 1 gram. And a regular follow-up is required for this patient. Now, how to manage the sexual partners? Evaluate and treat the sexual partners. See, we have to actually talk with the patient and collect the information regarding all sexual partners within the last 60 days of the disease. So if you are not able to, if the patient denies anything like that, you can ask for the last sexual partner if there is no contact with within the last 60 days. Now, this is another term which the postgraduate should be knowing about, is expedited partner therapy. Now, many times what happens, you are not able to track all the contacts in a sexually transmitted disease. So in that case, what is the feasible way? Only is you have to talk to the patients, and without examining the partners, you just give presumptive treatment for prescription or the drugs to the patient. So that is called expedited partner therapy. But this is not recommended for MSM patients because of high risk of coexistence of many extragenital infections as well as high risk behavior among these people. And they can even have a lot, like undiagnosed HIV infection, and they may be repeatedly going through the same procedure again in spite of our advice. So all those people, it is better not to go for EPT. So I hope this is useful for the postgraduates. So what are the take-home message? Detailed history taking is very, very important, because we get a typical history of contact and we get a rough estimate about the incubation period if you take proper history. And we should be aware of all complications, because like even if you are just checking the urethritis, we have to, ask the patient regarding symptoms of other areas of infections like pharyngitis, proctitis, epididymitis, etc. And presumptive treatment of chlamydia should be given along with treatment for gonorrhea if you are not able to rule out chlamydia by NAAT. And pharyngeal gonorrhea, the only test recommended by CDC is NAAT, because culture may not give a proper estimate about the infection or the organisms, as there are lots of non-pathogenic Neisseria in that particular area. And strict follow-up is required for rectal and pharyngeal gonorrhea because they have the high-risk behavior in them. And pregnant women should be treated at the earliest, as the gonococcal infection has many obstetric and neonatal complications. So I think this is clear, and if you have any doubts, you can please ask me.
Thank you very much. It's a very good talk. And I hope every postgraduate is very much benefited with this talk. Now, you have given a lot of practical points. That is most important. They can, even if they are not getting a question in examination, they will be benefited when they start practicing. So all this are very good as far as their future practice is concerned. So congratulations.
Thank you, sir. Thank you. I thought like theory they can read from textbook. Practical values, I think we experienced people should tell them, I feel, sir. Thank you, sir. All motivation from you, sir. Thank you so much.
Right. Thank you.
Thank you, sir.
Now we will move on to the second part of this webinar. Dr. Gopinath is going to talk now. He is an expert in sexually transmitted infections. Presently, he is a professor of MES Medical College. And this is important that when the patient comes with urethral discharge, how to approach clinically as well as by laboratory methods to reach a diagnosis. That is what is important. Of course, there should be very clear, as Dr. Roshni has mentioned, there should be a thorough history and physical examination, the planning of investigation, and so on. So a correct approach to a problem will give you the correct diagnosis. When there is correct diagnosis, the treatment will be correct. So and this important topic will be covered by Dr. Gopinath, and he will be talking on this. And over to you, Dr. Gopinath.
Thank you, sir. And thank you, Yusuf, for giving that opportunity. It has made my job much easier in giving you the overall view how to approach gonococcal urethritis. The same thing applies to any urethritis. To the another topic, urethral discharge. What is an urethral discharge? It is an abnormal purulent mucoid secretion from the fibromuscular tube urethra in male. Rarely it happens in female as well. So that indicates the inflammation that is happening in the urethra. There is what you call as in urethritis. There are normal secretions as well, urine and the preseminal fluid in male. And the abnormal urethral discharge, you can identify by the pathognomic laboratory finding of increased polymorphonuclear cells in the gram stain on the first void of urine. And it may contain the causative organism as well. Normally, these are all the infectious agents, bacteria, fungi, and virus. Less commonly, the other non-infectious like trauma, allergy, and neoplasm sometimes may also cause a urethral discharge. So if you take the epidemiology, right in India, we don't have much of a good registry, but almost this is the thing that I had taken a registry which has been some 5 years old. It says that there is roughly 15 to 20% of the people attending the STD clinics or the people are attending with STIs and other thing. Of them, the gonococcal urethritis is close up to 70%, and NGU up to 35%, and males are very frequently infected because they are very symptomatic. The females, they attend late because they are asymptomatic, usually very common in the younger age group, sexually active age group. And these are all the causative organisms. Since Madam has covered the gonococcal urethritis, I have taken up this thing, chlamydia, mycoplasma, and ureaplasma, and trichomonas, and herpes. How do they present? Usually they present with a burning urethral discharge, what you call as a urethria, dysuria, and there may be an increased frequency, and a meatal pruritus and redness will be there. And majority of the female, almost 50% of the females are asymptomatic. So this leads them at risk of getting an ascending infection that may lead to the infection of the fallopian tubes and lead to the pelvic inflammatory disease, ultimately leading to the infertility and chronic pelvic pain as well. So, since the males are symptomatic, they resolve without much complication since they present much early. At times, very rarely, they can also go for complications like urethral strictures, stenosis, and abscess formations, whereas the females are at risk of transmitting the infection to their partners, and also it possesses a risk for them to occurring other STIs and HIV as well, and leading to the ultimate late complications of PID and infertility. So early diagnosis and treatment is an utmost. So how do you approach the patient with urethral discharge? The detailed history taking is very much important, as said by Roshni Madam and I think. So then you have to do a clinical examination, look for any discharge. If there is no discharge in a male urethra, we can do a milking of the urethra and look for whether you can get some discharge, and always look for complications as well, and look for other associated STIs as well. Never ever forget to examine the rectum and or vaginal examination as well. And once you get the urethral discharge, whatever the thing, it has to be taken in a glass slide, and it has to be subjected to a gram stain, and a wet mount has to be done as well. This has to be done at the earliest very fast, otherwise the fastidious organism Trichomonas, you may not get it. Then the endocervical swab has to be taken. Madam has told how to take the swabs. It should not be in the cotton swabs or anything, because of the fatty acids in the cotton swab. They inhibit gonococci and other organisms as well. Usually a Dracan swab, another thing has to be used. And in male, we used to get a 2-glass and 3-glass and 4-glass test as well. So the 2-glass test is to look for whether the person is having an anterior or a posterior urethritis, wherein the person has to pass the first, say for 10, 15, 50 ml or 100 ml into the first glass, and then you look for the presence of threads and flocculations and other thing. In the 3-glass, the patient, we look for the posterior urethritis as well. The patient has to take the first some 20 ml or 50 ml in the first glass, then the second glass, another 10, 15 ml. Then the last void is, it represents the bladder and other thing. So whereas looking for the complication in the 4-glass test, as said earlier, the 2-glass test, the patient has to wipe 10 to 15 ml in the first glass and 50 ml for the second glass. And then we have to do a prostatic massage and then express the prostatic secretion, take for the test, and then the patient has to void empty the bladder, and that urine has to be subjected to the test, the loss. So when you do a risk assessment, you have to have a 5 P's important in his sexual history. Earlier, it was partners. We used to ask whether it is a male and female. Now, CDC has come out, WHO has come out with the thing of there should be a gender neutrality. And instead of asking, is it a male or female partner, what are the genders of your partner, may be the right question to be asked, and what are the practices the person has, and whether the person does any follow any protection for STIs has to be asked, any previous history of STIs, and the intention for pregnancy has to be asked. Earlier, we used to ask for any prevention methods and other thing. It is now the intention for the pregnancy. And the sixth P is pleasure, whether they are use any aspirational or other thing, which will make them at risk to develop. And people will venture in various modality of sex and ultimately end up with acquiring STIs. So there is another 8P question as well. I don't want to go in detail of the thing. So now, once you collect the specimen, before collecting the specimen, the patient should not have avoided the urine at least for 2 hours. Then only you have to take the discharge. Express this I had explained it earlier. If there is no discharge, and you can compress the meatus vertically to open the distal urethra, then insert the calcium alginate or Dracan flexible wire slowly and rotate it 2 to 3 times and withdraw, and then take the smear. This madam has told already, and this has to be sent under the microscopy in an ambient temperature, especially when you are looking for the viral culture and other thing. It has to be kept in 2 to 8 degree centigrade and other thing. Immunoassays, again, you have to keep it in the, when it is transported, it should be kept in a very low temperature. So I will start with the thing, little history of another patient who has come to us, who was a 26-year-old heterosexual male with complaints of dysuria, which has been recent onset of perineal and ejaculatory pain, which has been of 2 weeks, and with a history of unprotected sex with 3 casual sex partners 1 month ago. On examination, he had a scanty urethral discharge with no inguinal adenopathy or any other genital lesion, and general examination otherwise is very much normal. So being an urethritis and the urethral, we think about the most common things as gonococcal or chlamydia, mycoplasma and ureaplasma and trichomonas. These are the common things. So since it has been a scanty urethral discharge and mucoid discharge, and this specimen was also taken for the culture and sensitivity, and blood was also collected. You have to collect the blood to do other, look for other STIs as well. So the microscopy revealed that the person had numerous polymorphonuclear cells only. There was nothing else in the gram stain. So what do you think it could be? Gonococcal urethritis. So the iodine staining and was done, and that showed these brown color inclusion bodies and other thing. And the other stains that can be used, maybe Giemsa stain and Castaneda stain can be used. Immunofluorescence, it can be used. We don't have an immunofluorescence technique for this thing, but these are the other things that can be used. This organism cannot be grown in artificial media. It has to be grown in McCoy cell yolk sac media. And the other test that can be done is you can do an ELISA or complement fixation test, wherein the material that has been taken from grown in the egg yolk sac is injected to the forearm, and that was read. That is supposed to be read after 2 days, 4 days. Then you look for whether that is the patient develops a induration and nodules of more than 10 millimeter, then it is considered to be a positive skin test. So other methods are DNA probe and PCRs and chemiluminescence can also be done. So usually non-gonococcal urethritis, the commonest organism is chlamydia, or non-chlamydial and non-gonococcal urethritis like mycoplasma and other organism can also happen in the patients. And there is a coexistence of chlamydia in gonorrhea. It happens in 20% of the heterosexual men as well as homosexual and men. And this madam has earlier elicited very well. And so non-gonococcal urethritis, it is an infection caused by other pathogen other than gonorrhea. There are millions of cases that has been reported everywhere, and the incidence is equal in male and female, whereas the 50% of the women are asymptomatic, and since they then they will ultimately end up with PID and other thing. And whereas only the 1 to 2% of the men will have a asymptomatic presentation. You all know very well. So there are this organism has different serovars of the thing. A to C, they causes the trachoma or hyperendemic trachoma, and D to K serovar causes the genital tract infection and conjunctivitis and neonatal conjunctivitis. L1, L2, L3 serovars cause the lymphogranulovenereum as well. So chlamydia trachomatis is the most commonest organisms in person who is indulging with multiple sex partners, unprotected sex, and so common in low socioeconomic group as well. And about the organism, it is a gram-negative coccobacilli, which has roughly 350 nanometer size, and it is an obligate intracellular bacteria. And this, though being a bacteria, it has a life cycle which exists in a elementary body and as well as reticular body, and it doesn't have a cell wall, but in elementary body has a cell wall or the peptidoglycan and muramic acid with disulfide linkage that gives stability to the elementary body. And the females are affected 5 times more common than the male, and 2/3 of these patients will be asymptomatic. And because of the auto-inoculation, they can develop an ocular trachoma. And if the baby is born to an infected mother, it may develop an ophthalmia neonatorum. And the aspiration of the fluids may cause the neonatal pneumonia as well. So this elementary body, which has been endocytosed to the epithelial cells, then it increases in size almost 3 times of the thing to form the reticulate body. And this replication is continuous throughout, so as that the cell swells a lot and pushes the nucleus to one side of the cell, and which gives the appearance of a pendant or a clamp. That is how this organism has been named as chlamydia. And ultimately, once the cell is overstretched, it ruptures, and then the elementary body will be released out, and this infect the subsequent cells as well. So it presents in the male patients with mucopurulent urethral discharge and meatitis as well, with a short incubation period of 7 to 14 days, and with the history of dysuria as well. So if this was ignored, the patient will develop and may develop a urethritis, which usually end up in the ascending infection leading to the epididymitis and the scrotal swelling that is usually unilateral. Sometimes a systemic infection can also happen. And very rarely, in 1 to 2% of the patient, it may end up with a Reiter's syndrome. Otherwise, now the name has been changed to the Reiter's syndrome to the inflammatory arthritis, because the person has Reiter's, who has been a German, who has been involved in Nazis camp and other thing. That is why this name has been changed to the inflammatory seroreactive arthritis now. So look for other sides of the proctitis and other thing as well. So in women, it leads to cervicitis and urethritis, wherein the discharge will be a mucoid waterless vaginal discharge, and the patient may complain of a postcoital or intermenstrual bleeding as well, and ultimately lead to bartholinitis and a perihepatitis. with the PID, where you can have the violencing appearance of the thing that happens in the liver and to the diaphragm, what you call as the Fitz-Curtis syndrome. So this happens normally in people with other mixed infection as well. So very rarely, there is an associated risk for increased squamous cell carcinoma as well. So this is how the normal cervix looks like, whereas in the chlamydial cervicitis, you will have a punctate hemorrhage and then the mucosal mucoid discharge will be seen. And these are the two persons, Thomas Fig, it's Hug Jr. and authors Henley Curtis, who have described the syndrome. So in neonates, it presents with a conjunctivitis, what is called as inclusion oblinorrhea, presenting as a purulent discharge with swollen eyelids. When they aspirate, they may develop a subacute pneumonia, which presents after 1 to 2 months after the thing, and usually presents as afebrile and ultimately presents with cough and wheeze, and it predisposes one for developing an asthma in the later life. These are all the differential diagnosis. So what are the, how do you do the thing? Diagnose the thing is the first catch urine, send it for the nucleic acid amplification test, and then endocervical swab for the nucleic acid NAAT and culture. Vaginal swab has to be taken, as well as urethral swab has to be taken. So in the direct microscopy, usually you will be happen to see polymorphonuclear lymphocyte more than 5 in number, and that is with if you do a GIMSA stain, intracytoplasmic basophilic bodies will be seen, or even the iodine stain will show the brown intracytoplasmic antibodies because of the glycogen it contains. Other techniques are fluorescent antibody techniques. This can be done in the infected smear, all the smears. Complement fixation test we are not doing routinely now. And enzyme immunoassay is another test, and you can do a culture and sensitivity with McCoy cells or BHK2 cells or HeLa cell lines and as well. Nucleic acid amplification test is the highly sensitive, and it is the recommended first line of tests now. So about a word, the thing, earlier it was azithromycin was the drug of choice, but now there is a much of increased resistance for azithromycin. So this is the study done in different centers, thing which shows the azithromycin has a less efficacy compared to doxycycline. So earlier it was now uncomplicated. In pregnancy, it was azithromycin. Second line was doxycycline. If where you cannot give doxycycline, I think third line is ofloxacin can be given, or amoxicillin 500 milligram 4 times daily. This is for a pregnant lady. This was the thing. Now this guideline has been changed a little different in the CDC 2021 guidelines, and here you the pharyngeal testing is not recommended. Madam has told already another thing. And these patients, again, another study shows that doxycycline gives a much clear clearance than azithromycin. So now the treatment, if it is associated with pelvic inflammatory disease, you have to give cephalosporins in ceftriaxone 500 milligram IM, or cefoxitin 2 gram IM plus probenecid, and which is a costly affair, another thing. Plus doxycycline has to be given with metronidazole, looking for the anaerobic infections as well. If the person has an epidermolysis, ceftriaxone 500 milligram single dose plus doxycycline has to be given if you are not ruled out a gonococcal as well. If gonorrhea is unlikely, then you can treat it with ofloxacin alone. So about the reactive arthritis, I have told you, it is a triad where it happens in people with HLA B27 people who are at a tenfold increased risk to develop this thing, and wherein from the joint fluid, if you do a smear and nothing, you can look for the Penkin and cells and other thing that has been described by Penkin and Mellini in 1967. These are all actually macrophages that has phagocytosed the granulocytes. So it is a triad of the thing where the patient present with asymmetrical arthritis and with cervicitis and urethritis, diarrhea and conjunctivitis as well, presenting with keratoderma, balanitis and ulcers. So here the treatment is rest and non-steroidal anti-inflammatory drugs with the other treatment for chlamydial infections and gonococcal infection as well. So CDC guidelines now recommend for the chlamydial infection, doxycycline 100 milligram, BD for 7 days. If the person is pregnant, you can give azithromycin 1 gram single dose or amoxicillin 500 milligram 3 times for 7 days. Whereas in children who are been less than 45 kilogram, another thing, erythromycin 50 milligram per kilogram body weight per day orally divided dose for 14 days has to be given. And children who are weighing more than 45 kg can be given azithromycin as a single dose. And neonatal ophthalmia and pneumonia, erythromycin can be given 50 milligram per kilogram body weight per day orally for 4 days, or azithromycin as a suspension can be given. Screening is the most important thing that has to be done in non-pregnant women. Another thing, the patient under the age of 25 years who are been sexually active has to be screened for chlamydia and gonorrhea annually. And HIV testing has also been done. And this is the latest guideline that has been showing that hepatitis C at least once has to be done when the prevalence is much higher. Otherwise, it need not be done. Women with 25 years of age and older, they have to go for the testing of hepatitis C as well. Non-pregnant pregnant ladies, they have to go for the testing of HIV and syphilis at the first visit and at 28 weeks as well. Plus hepatitis B screening has to be done if they are not done earlier or if they are not been vaccinated. Whereas MSM, you have to do all the other STIs as well, plus hepatitis C and HIV has to be screened. Transgender people, based on the current anatomy and the gender of the sex of the person, offer HIV screening, and these people has to undergo gonococcal and chlamydial screening at all the sites like oral, anal and genital regions, and then the urine and the neovaginal swab may sometimes has to be taken from the thing. But in a neovaginal area, normally, since it is a stratified squamous epithelium, it is not usually infected with gonorrhea. So again, the same, consider screening for GC and chlamydia, and pharyngeal GC has to be screened. Coming to the second organism that is most common is Mycoplasma genitalium, which causes non-gonococcal, non-chlamydial urethritis, as well as Ureaplasma urealyticum, another organism which belongs to the Mycoplasma family. But since it breaks down the urea to produce ammonia and carbon dioxide, it is called as Ureaplasma urealyticum. And Trichomonas vaginalis also accounts for 1% of the infection. Usually they present as asymptomatic urethritis. And about the word about the Mycoplasma, it is the smallest living free organism. And earlier it was called as a PPLO, pleuropneumonia like organism, another thing. And now it has been called as Mycoplasma. Majority of the people that it infects the men very commonly. and they like a cell wall, and so they cannot be stained by the gram stain, and it needs a very complex growth requirement, and it is very slow to grow. It takes up to 6 weeks as well. So though there are almost 100 microorganisms, only 15 of the mycoplasma are infective to human beings, ultimately leading to the urethritis, pyelonephritis, and PID, and postpartum fever as well. So the test what you do is now cold agglutination test, because there is an adherent protein, PI protein, which attaches to the epithelial cells. It induces the autoantibody production and other thing to the RBC and causes clumping of RBC at 4 degrees centigrade. That is why it is called as a cold agglutination test as well. These are the things that nowadays we are not doing those tests, and treatment is as same as chlamydia, has to be treated with doxycycline. Till now, there is no vaccination that has been available. Culture has to be taken from the first void urine or the urethral swab, whereas the vaginal swab is preferred in ladies and women's, and transportation has to be done in a ureaplasma, that it has to be transported at a 4 degree centigrade and other thing, because it is a very it is a very fastidious organism, and nothing has to be kept in a low temperature. The urine specimen are best transported directly or within with 4 degrees centigrade within 24 hours has to be transported. Regarding the culture technique, where to take from the sample, this has been mentioned early. It is same as the gonococci. It has to be taken, and the thing, traditionally it has been kept in the beef or infusion broth, supplemented with arginine or urea for the medium of mycoplasma hominis and ureaplasma. Nucleic acid amplification test is a very easy test. The transportation is done in the compatible media with a phosphate buffer saline transportation. Dry transportation can be done for the vaginal specimen. So, whereas these immunofluorescence, other PCR tests can be used to identify these organisms, which are very easy technique, and the thing, the commercial kits are available now, as a point of care test also is available now. The mycoplasma, it produces a fried egg appearance, whereas ureaplasma in the culture doesn't produce a fried egg appearance. So these are the other media that can be, the culture has to be inoculated and then monitored for the growth in the PCR. PCR looking for the targeting the MGP antigen and gene has to be done. And NAAT can be done in the urine. Serology can be done doing with the enzyme immunoassay and other based upon the lipid associated membrane protein can be done for the Mycoplasma genitalicum infection as well. Coming to the next organism, Trichomonas vaginalis. This is a most common STI in female, but infection in men is very less. 20% of the men may have present with this thing. Usually, Trichomonas vaginalis is an important cause for the recurrent persistent urethritis, and this increases the person's risk to acquire HIV to a twofold. Yeah, morphologically it is a flat oval body with an undulating membrane and 4 flagellas in the anterior and axostyle, and there is an undulating membrane which has been in the half of the body that present, and then there is an axostyle in the center of the body. And it has a reservoir. Only humans are the infective material. It spreads from one person to another person, and it divides by the binary fission. And it doesn't present with a cyst form or other thing. It present only with a tropocyte form, another thing. Causes a symptomatic and asymptomatic infection in men and women. The vaginitis is the commonest thing, where you have the copious vaginal discharge and itching. The cervix shows a punctate hemorrhage called as strawberry cervix. If the person is not treated or picked up very early, it may lead to the preterm labor and premature rupture of membrane with a low birth weight and other thing. So how do you approach the thing? Take the thing, take a wet smear and look for the thing. You can look and you can look for this tropocyte and another thing. So, and again, a prostatic massage and other thing can be done, wherein if you didn't get this organism in the first void urine or other thing. So culture medium is diamond Trichomonas medium, as is the gold standard. And there are pouches are also available, wherein you can put the material in the pouch, and this pouch can be examined after 2 to 4 days for the organism. Usually, so it produces a very clear, this, because of the presence of this undulating membrane, I think it produces a jittery movement, which is fine. Microscopy done in a saline wet mount and look for the motile flagellated parasite that we have just now seen, or a smear can be done. And rapid antigen test is very much sensitive. And this is another method. Papa-Nicolau stain can also be done. DNA probes and PCR and culture are other methods by which you can diagnose the thing. So as I said earlier, clinically in females, it presents with a copious malodorous greenish vaginal discharge with a dysuria and lower abdominal pain. The vaginal wall shows a punctate hemorrhage, and the cervix shows a hemorrhagic spots, which has been called as a colpitis macularis or strawberry cervix. Diagnosis, and I think that has been that I had explained earlier. So what is the treatment? The recommended treatment is metronidazole 500 milligram PAD, but 500 milligram is not available for us. We give 400 milligram TAD for 7 days. And in males, you can give a 2 gram oral single dose as well. Expedited partner therapy is reasonable, and this can be done except for the gay persons, or it can be done for other persons. And it has been legalized now. We can treat it with the expedited partner therapy as well. So wherein you can give tinidazole or as well as an alternative therapy, 2 gram stratum. Diagnosis usually is by PCR is a rational test for. Now they are telling us, no, you need not go for the wet mount, but we do still rely upon the wet mount testing and otherwise. A word about the metronidazole and alcohol. Earlier, it has been thought it may produce an disulfiram-like reaction. It has been stated very clearly it doesn't produce a disulfiram-like reactions, another thing. So treatment, this part I had covered earlier. The last other thing is organism that causes urethral discharge and another thing, vaginal, it's a Gardnerella vaginalis, which causes a bacterial vaginosis, which is an anaerobic bacteria, presenting with a pruritus and dysuria. Clinically, the patient will present with a foul swelling, copious vaginal discharge and fishy odor. And you can do your staining and look for the clue cells. This is the normal vaginal cell, whereas this is the clue cell which has been attached with the coccobacilli onto the vaginal wall. Treatment is again metronidazole. So other diagnostic criteria, another thing that is Amsel's diagnostic criteria. wherein we can do the thin homogeneous vaginal discharge with a pH which has been greater than 4 and positive whispers or an amine test, where over the secretion, if you add a 10% potassium hydroxide, if it produces a fishy amine water as well, and the presence of 20% of the clue cells in the secretion is another clue. So this is the mnemonic to look for the thing, adherent bacteria and milky discharge and the stench, the odor it produces, and the elevated pH as well. Because it's a very complicated scoring system, Nugent score system, it doesn't use nowadays. So what is the treatment guidelines or the thing? So the patient has to be treated with metronidazole for the treatment of bacterial vaginosis, as for has to be treated 400 milligram TAD, or a 2 gram statum has to be given. Fine. So having said that, since we didn't have a vaccine still now for all any sexually transmitted urethral discharge or another thing, the prevention is the most important thing, wherein we have to encourage the patient to have a safe sexual practices, and partner notification and testing has to be done. Vaccination, we don't right now don't have a vaccination for urethral discharge causing organisms, and so those are the earlier what I have told is the CDC treatment guidelines. But on a syndromic management, now NACO gives the kit 1, which contains the azithromycin 1 gram or cefixime 400 milligram for urethral and anorectal discharge or cervical syndromes with asymptomatic infection as well. This has to be given to the patient as well as to the partner as well. So we have to educate the patient, counsel the client regarding practicing a safe sex practices, treat all the partners. If possible, advise abstinence and condom use during abstinence is the best method, or if not possible, condom use has to be encouraged. And how to follow up all the things? These patient has to be followed 7th day and 14th day, but NAAT another thing may be positive till 14 days. Ideally, the follow-up testing has to be done after 21 days. If symptom persists, again, look for whether the person has got a reinfection, and vaccination is against hepatitis B has to be considered. So this is the how to approach the patient in short. If the person with a genital or urethral discharge comes, take a history, examine and milk the urethra. If the urethra discharge is there, do a gram stain or the wet mount or other thing, do the thing and look for the presence of gonococcal or chlamydia. It has to be treated accordingly, as we had explained earlier. If there is no discharge, then the patient has to be followed up, and you have to do the 2-glass and 3-glass test as well, and 4-glass test as well. Look for the presence of any discharge that you get, that accordingly it has to be treated again. If there is no discharge, and I think in spite of all these things, you can educate the patient, and HIV counseling has to be given, and ask the patient to come for review for 7th and 14th day as well. After taking the sexual history and I think after doing the thing, perform the test. If the point of care test and other thing are available, and if the results are available right at the same day, another thing you have to treat it with for gonorrhea and chlamydia, because we know it very well. It is very difficult to get the STI patients for the review or come on a subsequent date with the results. We usually treat them at the time of consultation as well. In the limited laboratory finding where you don't have limited setting or where there is not urethral discharge which has not been available, the patient has to be offered HIV and syphilis testing. If the partner have a definite diagnosis, this the person has to be treated as well according to the partner's infection. Again, so milk the urethra. If discharge confirmed, you have to treat and educate. It is condom promotion has to be provided, and then they have to be educated against all the risky sexual behaviors and other thing, and the patient has to be reviewed after 7th and 14th day as well. So conclusion, in STIs are very common. In our OPD, it accounts for 2 to 3% of the OPDs. And after the COVID, ulcerative and genital discharge is very common. The asymptomatic infection poses a great risk to the patient as well as to the partners and to the society at large. So importance of education and awareness has to be given, and early diagnosis and treatment. We can avoid these patients end up with long-term complications as well. Thank you.
Thank you very much, Dr. Gopinath. It's a good presentation. I hope the students have benefited out of this today's webinar, and hope all of you have enjoyed the webinar. Let it be a starting point for your preparation of final year examination, and both the speakers have given you enough and more clues and information regarding both gonococcal urethritis and approach to urethral discharge. So, Dr. Roshni and Dr. Gopinath did a very good job.
Thank you, sir. Thank you.
Yeah.
Thank you, sir.
See you next.
Thank you so much, sir. Thanks for giving opportunity for research pharma. And our postgraduates are requested to kindly, this time very good participation, about around 80 participation has arrived at this time. So kindly share the details to other PGs also, let them be benefited. Thank you so much for giving opportunity. And my cordial thanks for postgraduate Dr. Ketan sir, and the great talk from Dr. Roshni madam and from Dr. Gopinath sir. Thank you so much for this.
Thank you.
Thank you.